Good morning, everyone. I'll be presenting sensory and motor outcomes after surgery in intermittent divergent squint. Okay. So IDS is an exodeviation that is controlled intermittently by the fusional mechanisms, and it comprises about 50 to 90% of all the cases of exotropia. And as it progresses, there is deterioration in stereoacuity noted. The primary objective was to see the sensory and motor outcomes, and the secondary objective was to see the correlation between sensory and motor outcomes and to compare these parameters between cases and controls. This was a prospective observational study which included 34 cases and 34 controls, and it was conducted at RP Center AIMS. The patients who were diagnosed with basic IDS, they were taken up for the study, and they were followed up at day 1, 1 month, and 3 months after surgery. The inclusion criteria and exclusion criteria are mentioned as below. On examination, we tested the stereoacuity, near stereoacuity using the near Randot test and TNO test, and distance stereoacuity was tested using distance Randot and Frisbee-Davis distance test. And Newcastle score was also calculated, and prism bar cover test was done. The fusional versions was seen, and the breakpoint and recovery point was calculated. The demographic data was comparable between the cases and control groups. When we compared the near stereoacuity, significant difference was seen in the stereoacuity and was significantly lower in the cases group as compared to the control, and same goes for the distance stereoacuity. On follow-up after the surgery, we can see there is significant improvement in the stereoacuity at 1 month post-surgery, and it continued to improve over the next 3 months, but still at 3 months it was significantly lower as compared to the control group. The motor control, that was improved significantly at 1 month, and no changes were noted between 1 and 3 months. Fusional convergence also improved significantly. When we compared when we see the correlation between the sensory status with motor control, the pre-operatively we see a significant correlation, but in post-op the correlation is not that significant as compared to the pre-operative period. And when we do the pairwise comparison, we saw that the gain in stereoacuity is poor in cases which are taken up for surgery after the Newcastle score deteriorates for more than 5. So the conclusions of our study were that the distance and near stereoacuity, they are significantly lower in IDS patient as compared to the age and gender matched controls, and significant improvement is noted in the sensory parameters at 1 month post-surgery, which continues to improve over the next 3 months, and significant improvement is also seen in the motor control, which is comparable to the control group at 1 month post-surgery. And the most important conclusion which we saw were that when the cases are taken with modified Newcastle score more than 5, the prognosis becomes poor in terms of the gain in stereoacuity. So we recommend that the surgery should be done before the Newcastle score deteriorates to more than 5 to get a better outcome. Thank you.
Thank you, Dr. Nantara. I guess stereo is one of the predictors which actually tells you, not only tells you when to operate, but also tells you about the post-operative outcome. And Newcastle score is a very nice subjective way of assessing when you should operate, because stereo is also a subjective way, but Newcastle scoring clinically you can assess even if you do not have the stereo available at your centers, the stereoacuity cards. But based on Newcastle scoring, if you feel the scoring is this much, that gives you an idea about the timing of intervention, right?